This is Dr. Joe DeStefano from Urgent Care 24/7. Life is 24/7, and so are we. We're going to have a chat today about hypothyroidism. The thyroid is a gland that sits here in front of your trachea in the front of your neck. It makes thyroid hormone, and thyroid hormone is kind of the master controller of your rate of metabolism. It controls the balance of your muscle fibers, slow twitch and long twitch, is essential in growth and mental function. And the thyroid gland takes iodine and makes thyroid hormone. The active form of thyroid hormone it makes is T3, and the kind of storage form of thyroid hormone it makes that sits in the background and gets converted to T3 is T4. But like most endocrine systems, it is under the control of the master gland, the pituitary gland that sits in the brain, kind of up at the top of the inside of the nose, between the eyes. And the pituitary gland takes some cues as well from the hypothalamus, which is kind of the base of the brain that controls a lot of hormonal release by controlling the pituitary. So in a normal functioning person, you have thyroid releasing hormone in the hypothalamus. It hits the pituitary. The pituitary makes thyroid stimulating hormone. That goes to the thyroid, stimulates the thyroid, and the thyroid makes thyroid hormone. And then if the thyroid hormone levels go too high, a negative feedback loop happens. The brain senses the thyroid levels are too high and releases lower amounts of TSH, and the hormones come back in the nice area. In hypothyroidism, something gets short-circuited. The thyroid stops making enough thyroid hormone, and all types of bad things start happening at that point. You start to have the heart not pump well, the actual balance of muscle in the heart starts to get wrong, and the heart actually gets weak, and people start to develop signs of heart failure. There isn't proper turnover of fluids in the body, and people start to get what we call mixed edema, which is like this muddy edema of the tissues. It affects the neurotransmitters in the brain, and people become depressed. If the thyroid hormones are low enough, long enough, they'll actually go into a coma, and it's called mixed edema coma. And that can be life-threatening and very difficult to manage, and people have to go into the hospital and get IV thyroid hormone and IV cortisone, and it's a real endocrine emergency. It's fairly rare, though. More commonly, people have hypothyroidism and they just kind of feel lousy, are depressed, have decreased exercise tolerance, constipation, and kind of swell and don't know why. Most thyroid disease is autoimmune. So what happens is the body decides it does not like the thyroid and starts attacking it. And under attack, the thyroid cannot make enough thyroid hormone. This is a form of primary hyperthyroidism, primary hypothyroidism in terms of that the gland itself is affected. Primary. It is diagnosed by a low T3, low T4 level, and a very high TSH level as the pituitary tries to beat on the thyroid to make the right amount of thyroid hormone. And the thyroid is saying, oh, pituitary, I can't make any more. I'm sick. I'm under attack. Then you also have a secondary hypothyroidism where the pituitary has something wrong with it, or the hypothalamus, and the thyroid isn't making thyroid hormone because it's not getting the signals from the brain to make enough thyroid hormone. You also can get hypothyroidism from iodine deficiency because iodine is needed to make thyroid hormone. That is almost unheard of in the United States because they supplement iodine in the salt and in the other sources of food. Now, management of thyroid. There's a lot of misconceptions about managing hypothyroid patients. And this is the difference between the practice and art of medicine and just cookie cutter medicine. The range of what a normal TSH is has changed over the years as the tests have gotten more sensitive. Plus, you really don't know what somebody's healthy TSH level was before their thyroid started malfunctioning. You know, you don't generally get a TSH level until somebody is symptomatic. So what was their normal TSH when they were like 16, had no autoimmune disease, and were young and vigorous and was not sick? You don't know. We used population normals. And so we feel that a normal TSH, for example, is 0.5 to 4. That's a big range. And maybe this particular person had when they were healthy and young and vigorous and the thyroid was functioning like it should and everything was working, maybe their free T4 level was 1.8 and maybe their TSH level was 1. You don't know. So I've seen it done where patients come to me and they say my doctor won't listen to me. He only checks my TSH level. He says my thyroid level is fine. My TSH level is 4. I still have symptoms. I am still constipated. I am still swollen. I am still depressed. That tells you that the patient's TSH level suppressed to 4 is not enough. That would tell you that if their free T4 was 0.7, that is not their normal free T4 level for their biology in their individual body because they still have symptoms. And there's other secondary lab work findings that could tell you that your patient does not have adequate thyroid replacement. One of these, which is a deep secret of endocrinology, is what is the patient's triglyceride level? Patients that are under-replaced on their thyroid tend to have high triglycerides, triglycerides greater than 300. So when I manage thyroid patients who have actual thyroid disease, these are not well patients just being screened for disease, but I know they have Hashimoto's autoimmune thyroiditis. I know they have secondary hyperthyroidism from a pituitary tumor or autoimmune pituitary disease. I look at the TSH, the T3, the free T4. I examine the patient and I take a thorough history of the patient and I look at the patient's other biochemical markers. So if a patient comes to me and their TSH is 4, their free T4 is in the normal range, but they have slow to relax reflexes, they're telling me that they're still constipated, they're still having swelling, they still feel that they may be somewhat depressed, and their triglycerides are 600, I will increase their thyroid and reassess them in 3 months to see how they feel. A lot of times that's all I have to do. They come back, their TSH is suppressed below 4, maybe down to about 1. Their free T4 may be up to 1.9 or even 2, which is the top of the normal level. Their triglycerides have come down to 150, and they tell me my leg swelling's better, my constipation's better, I feel the best I've felt since I was a teenager. Now, there is been a school of thought in public health that you do not have to look at anything other than the TSH. If the TSH is less than 4 and normal, it doesn't matter what the rest of the panel is. That came from over-application of some data about screening for hypothyroidism. When you screen for hypothyroidism, the most efficient, cost-effective thing to do is just check a TSH. If the TSH is high, they're probably hypothyroid. But the next step is always a complete thyroid panel, looking at the other biochemical markers such as triglycerides, a good history, looking at symptoms, and a physical exam. This is Joseph DeStefano, MD, for Urgent Care 24/7. Life is 24/7, and so are we. Thanks for having this chat with me today about hypothyroidism.